Good morning. Welcome back to Open Med School. Today I am going to discuss with you regarding homonymous hemianopia and how to localize visual field abnormalities. So this is a history of a 78-year-old female. Her complaint is right-sided visual disturbance. General examination was normal. Visual acuity was normal. Confrontation test showed right homonymous hemianopia. Pupillary examination, rest of the nervous system examination was normal. So the first thing in any neurological case is localization. For that we should know the visual pathway. So here is the optic nerve, this is optic chiasm, this is optic tract, and here comes the optic radiation. So you can see the visual fields. If you represent like this is for the right eye and other is for the left eye. We have got a nasal part and a temporal part. The temporal visual field, the images are falling on the nasal part of the retina. From there the fiber pass via the optic chiasm. It goes to the opposite side, relay in the lateral geniculate body, from where the optic radiation goes to the occipital lobe. So this is the basic anatomy we should know. Whereas the temporal half of the retina, that is representing the nasal visual field, passes without crossing the chiasm and goes to the lateral geniculate body. From there, just like the nasal fibers, it goes to the occipital lobe. So the main lesions in the visual pathways can be one at the level of optic nerve, second at the level of the chiasm, third is at the level of the optic tract, then at the level of the optic radiation. Let us see how to differentiate. Any lesion anterior to the chiasm. So take the chiasm as the central point. Anything anterior, it will produce unilateral visual loss, that is anopia. So somebody comes with a visual loss in one eye, provided ophthalmological causes are ruled out, you can be certain that it is due to an optic nerve problem. Chiasmal lesions characteristically produce bitemporal field defect. As we already discussed that the nasal part of the retina represents the temporal visual field and it is going through the chiasm. So any lesions in the chiasm produces bitemporal field. So this is the typical finding of a optic chiasmal lesion. Then comes the retrochiasmal. Any retrochiasmal lesion, the rule of the thumb is it will produce homonymous hemianopia. What do you mean by homonymous hemianopia? Homonymous hemianopia means in the right eye, if the right half is, that is right side, that is a temporal visual field is gone, and the left side, it is a nasal field is gone, it is the right-sided visual loss is occurring. So that is called a right homonymous hemianopia. If it is on the reverse way, that is on the left eye, the temporal field is gone, and the right eye, it is a nasal field is gone. It is the left side of the visual field is gone. So it is called a left homonymous hemianopia. So we should understand one point. One is what is homonymous hemianopia. Second point, if you get a lesion of right-sided homonymous hemianopia, that is right homonymous hemianopia, just like a patient with hemiplegia where the lesion is on the opposite side, just remember that the lesion is on the opposite side. That is right-sided retrochiasmal lesion will produce left homonymous hemianopia and left-sided retrochiasmal lesion produces right homonymous hemianopia. This is an important point to be kept in mind. Then we have to differentiate what are the differences between an optic tract lesion and optic radiation lesion. We will discuss this. So if you remember the pupillary light reflex, the pupillary light reflex, the fiber doesn't go and relay in the geniculate ganglion, lateral geniculate body. Without that, it goes to the midbrain. It goes to the pretectal region where it relays, and from there it goes to the Edinger-Westphal nuclei. Edinger-Westphal nucleus is a midline nuclei, so this will give parasympathetic outflow to both the third nerves, and this will produce constriction of the pupil because of the parasympathetic outflow from the Edinger-Westphal nuclei. So if a lesion is in the anterior part, that is the optic tract is affected, that is anterior to the lateral geniculate body, you may get involvement of the pupillary light reflex. And the typical pupillary light reflex is called Wernicke's pupil or Wernicke's hemianopic pupil. What is meant by Wernicke's hemianopic pupil? This is seen in optic tract lesion. So if you stimulate the blind half of the retina, the pupil will not react. If the light is falling on the normal area, that is the visual field is normal, that area, if it is falling, it will produce a constriction. This is called Wernicke's hemianopic pupil. It is very difficult to identify clinically, and you may have to use a narrow streak of light. So the ordinary light reflex, the torch cannot identify. You may have to go for a slit lamp or a narrow streak of light. It is difficult to identify, as already mentioned. But the point to be remembered is somebody has got a bilateral lesion of the optic tract. Bilaterally, the pupils will be, pupillary light reflex will be absent. So the important point is, when somebody comes with blindness, the pupillary light reflex is preserved. That means it is a optic radiation rather than an optic tract lesion, because in a optic radiation lesion, the fiber for pupillary reflex has passed from the optic tract without relaying to the lateral geniculate body, and it has gone to the Edinger-Westphal nuclei. Hope that point is clear to you. So we have already mentioned, from the lateral geniculate body, the fibers are going as the optic radiation. So this passes through the temporal lobe, and also some are passing through the parietal lobe. So lesions in the parietal lobe can produce hemianopia, lesions in the temporal lobe can produce visual field abnormalities, that is homonymous hemianopia. The fibers that is passing through the temporal lobe is called the Meyer's loop, and the Meyer's loop for the temporal part is representing the upper part of the visual field. So if there is a lesion in the temporal lobe and the Meyer's loop is involved, you get a superior quadranopia. And in the case of a parietal lobe lesion, you get a inferior quadranopia. We'll explain this a little more. So this is the lateral view. Here comes the lateral geniculate body. From the lateral geniculate body, the fibers are passing through the parietal lobe. So this is the optic radiation passing to the parietal lobe. Here comes fibers passing through the temporal lobe. This is the Meyer's loop. If the Meyer's loop is affected, Meyer's loop is representing the fibers for the upper quadrant. So it will produce a superior quadranopia. So here you can see there is a visual field defect of similar size, almost similar size on the both sides, and the upper part is affected. This is called a superior quadranopia. Hope this point is clear to you. So this produces a right. So this lesion is a right superior quadranopia, and this is characteristic of Meyer's loop involvement. So here you can see the patient has got a homonymous hemianopia. That is the on this half, this quadrant the field is gone, and the other quadrant also the field is gone. This is on the same side, so it is a inferior quadranopia. So it is on the left side, so it is called a left inferior quadrant hemianopia. As I already mentioned, if the finding is on the left side, the lesion should be on the right side. So this is a right parietal lobe involvement. Hope this point is clear to you. So let us see what is this field defect. Here you can see that this macular region is paired. This is called macular sparing homonymous hemianopia. So what is in this macular sparing and what is the reason? So here again you can see it is a homonymous. The left half of the visual field is lost. So it is a homonymous hemianopia. Macular region is paired, so it is called a macular sparing homonymous hemianopia, and is almost same size. So it is called a congruous type. So the one point you remember is that as the lesion becomes more posterior, the lesion is congruous. So you can take the converse. If you get a congruous type of hemianopia, it indicates a occipital lobe lesion. So what is the basis of this? So if you remember the blood supply, the part of the occipital lobe where the macula is represented has got bilateral supply. So it is the terminal branches of the posterior cerebral artery and also branch from the middle cerebral artery supply. So there is a dual blood supply. Because of this, when the posterior cerebral artery is occluded proximally, the major chunk of optic radiation is affected, but the macular region is spared. So what will you get? You get a homonymous hemianopia which is congruous with the macular sparing. A few words regarding the temporal crescent. Here you can see that 60% of the visual field, the nasal part, has got bilateral representation. And you can see the outermost aspect, a crescent shaped portion. This is only represented on one side. So rarely a lesion in the occipital lobe situated anteriorly can affect this part of the cortex. That is, the representation of this area only can be lost, and you can get a unilateral temporal crescent area visual loss. It's a very rare thing. Just for the completion's sake, I have mentioned this. So the rule of the thumb: a lesion anterior to the chiasm produces unilateral visual loss. Posterior to the chiasm produces homonymous hemianopia. Chiasmal lesion produces bitemporal hemianopia. This is the major point to remember. The only exception, the missing of the temporal crescent or a half moon syndrome, can very rarely occur in occipital lobe lesion. And finally, we will summarize the features of an occipital lobe lesion producing visual field abnormality. One, it is congruous. Congruous means the symmetry is there. Second is macular sparing. We have already mentioned macula has dual supply from the middle cerebral artery and posterior cerebral artery. So sometimes an occipital lobe lesion, especially due to posterior cerebral artery problems, can spare the macula. We have mentioned about the crescent sign. That is, a crescent shaped area can alone be lost in occipital lobe lesion, or sometimes this can be preserved because that area is situated a little anteriorly and can be escaping in a ischemic or hemorrhagic lesion. And third is a pupil. The hemianopic pupil, Wernicke's hemianopic pupil, is classically seen in homonymous hemianopia due to optic tract lesions. And in optic radiation, the pupils will be normal because the pupillary fibers are going to the pretectal region before entering the lateral geniculate body. That is again an important point to be kept in mind. Hope you have enjoyed this video, and if you like this, please subscribe to my channel. Thank you.